Welcome to the University of Cincinnati Internal Medicine Residency tutorial entitled Patient-Centered Bedside Rounds. After this presentation, you should be able to round at bedside with an internal medicine ward team using patient-centered rounding techniques. Before we review the 15 steps in our model, I'd like to make two comments. First, although there are 15 steps and they are listed in order here, these are not necessarily done in order. They're often overlapping and occur at the same time. And second, although there are 15 steps, there are many ways to be patient-centered, and these are just a guideline. We try to be flexible in our rounding, and the only dogma that we adhere to is that we will be patient-centered. The 15 steps that we have here are: ask the patient permission and get a set of expectations into the patient's mind, pre-review the data, organize the team, check for safety, introduce the team, introduce the patient, engage the patient directly when presenting, involve the team in whatever checklist and routine that you use, role model, teach and learn from all, use Teachback, assess the learner, organize work after rounds, debrief, reflect, and give feedback, do a post-round visit, a check-in, and another Teachback, and then improve and repeat the process. As we review the 15 steps, you will see a series of pictures that have been screen capped from videos that we've created to illustrate each point. If you'd like to see these videos in more detail, you can go to YouTube and type in the keyword UCINTMED. The first step is to ask the patient permission and give a set of expectations for what patient-centered rounding might be like. Once you describe patient-centered rounding and traditional rounding, give the patient the choice for what they would like. In our experience, most patients prefer to have patient-centered rounding. Many people are concerned that if they have a lot of people in the room, they may embarrass the patient in some way. So before you round, ask this question to the patient: what do you feel comfortable talking about during these rounds? If the patient says they're comfortable, then you can talk about it. If they say they're not comfortable, then don't talk about it. But the goal is to give the power to the patient. We create a series of rounding cards that simply have our faces and names. It tells the patient who is coming, and in case they forget our names, they have our pictures and they can say, hey, this is my doctor. We also leave a place for notes where we write them notes and they write us notes. This has been a huge patient satisfier. In a 2013 article entitled The Art of Bedside Rounds, a multi-center qualitative study of strategies used by experienced bedside teachers, Gonzalo et al. Created a table called Prioritization of Patients Chosen for and Deferred for Bedside Rounds. We disagree with many of the things on this table, and we want to explain to you what we use to choose who to bedside round on. Very simply, we round just about everybody. But let's look at what they put in the table and see if we agree or disagree. They said, definitely perform bedside rounds on sick patients, new admissions, and post-call days. We totally agree with that. Likely perform bedside rounds on people with clinical decision-making that is required, high educational value for trainees, geographic considerations. Yes, we agree. They said, variable depending on time, patients pending discharge, house staff preference, clinically stable patients with low educational value. We disagree with that. We think that you should be rounding on all of those patients. First of all, patients pending discharge are the most vulnerable patients in the hospital often, and we have to get that right. House staff should not direct who you round on. And finally, clinically stable patients with low educational value indicate that that's not very patient-centered. That's kind of resident or attending-centered. Patient-centered means this patient needs our care, and we need to be fully present. So we disagree with these things. Sensitive issues anticipated in discussion, well, that is variable depending on whether you've gotten permission or not from your patient. To walk in without having permission is to set yourself up for failure. Patient on contact or respiratory isolation. This is a problem oftentimes in the wintertime when a lot of people are in precautions of some type. In that case, your team has to decide, is it risk-benefit to have everybody in the room or just the people who need to take care of that patient directly? And that should be your choice. Patient not available or off the floor. Well, you shouldn't defer bedside rounding on them just because they were off the floor. First of all, organize your day so you know where the patients are and round when they are present. And second, if you miss them, come back and still round them in a patient-centered way at bedside. They shouldn't be penalized because they were off having a test. Patient status impairs inadequate communication. You know, this is one of those things where we think there's value in being at the bedside to try to see a patient who is sick rather than trying to round away from them. And finally, unwilling patient, we agree. If you don't want to do bedside rounds, you shouldn't be subjected to it. Step 2 is to pre-review the data, and there are multiple layers to this. In the old days, the only way that you could get information from one person to another was to read it to them. There was no electronic medical record, and the residents often carried the notes around in their pockets, and they had to read it to you, otherwise you couldn't see it if you were the attending physician. Now with the electronic medical record, the transmitter of information should not be the resident reading to you. It should be the computer for which the resident has put the information in. So on the after the call day or regular day, you should be talking with your resident to seeing how the information went in the afternoon or early evening. And then in the morning, attending physicians should get to the hospital early and review all the things that have been written about that patient. So you walk in to the patient room being informed, and you do not have to read everything at the bedside. Step 3 is to organize the team, and there are multiple layers to this as well. This is what our teams consist of: a nurse, students, case managers, interns, the attending physician, the pharmacist, and the senior resident. We usually ask the senior resident to organize the team so that everybody has a role to do when they walk in. You don't want a lot of inertia here. You want people to be active. Step 4, check for safety. Again, there are multiple layers. Many interns fear that they will make a mistake in front of their patient and be embarrassed. And this is possible, but it should not happen. A question that we like to ask our learners is, hey, you got this one? Let's not walk into the room being unprepared. Now, residents have to use their judgment. Do they understand what's going on? This is where that pre-review happens. Senior residents should be helping interns get prepared for these type of rounds. Check for safety. Step 5 is to introduce the team, to let the patient know who's in the room and what roles they have. Everybody has a role to play, and they should articulate that. This should be backed up using the rounding card. Step 6 is to allow the patient to introduce him or herself, to let them be the center of this attention since it is their rounds, and have them tell you who they are and what they're about. Step 7 is where we get a little bit different. We have engagement directly with the patient, where the resident tells the patient what's been going on instead of directly to the attending. So an example might be, Mr. Jones, you came in last night, you were telling us that you had chest pain. It was in the center of your chest. It went over to your left arm. At this moment, Mr. Jones is invited to interrupt to be part of his history. This is a great way to get patients engaged and to be fully heard. Importantly, do not recapitulate table rounds at the bedside. If you talk in third person or talk over the patient's head, you will set yourself up for failure. During the history portion of this, it's important to have that patient confirm the history. You cannot do that as the attending physician because you weren't there and you're not the patient. The patient confirms the history, not you. Attending physicians need to be flexible when learning to manage these moments because patients, as they contribute to the history, things often change, but this is okay because, again, you're meeting the patients where they're at. When you do the exam, ask permission. Can we examine you together? Try to do it all at once. As the senior resident or the resident is reading the exam to you or telling you what they found, you can confirm it right there, giving them instant feedback. And you can often involve other learners, like medical students and other residents, in the exam as it is reviewed. When reviewing the labs, tailor this to the patient, don't sell them short. One of the most important features of a physician's job is to take complex information and make it relevant for the patient. You get to see residents do that in real time. Don't read all the labs, sodium 142, potassium 3.8. Don't do that. If the kidney profile is normal, you can say the kidney's profile is normal. If you're following a particular lab, like creatinine, you can explain it to the patient in a way that they can understand. For example, you could say, the kidney is a big filter, and it filters things out of the blood. One of the things it filters is this thing called creatinine, which comes from your muscles. Normally, we have a creatinine of about 1, but when the creatinine rises, we know the filter is not working. So your creatinine was 3, and today it's 2. That way, when you walk in the room tomorrow, they can know, hey, what was my creatinine, for example. If the patient has a PhD, you may use different techniques and strategies than if the patient has a 5th grade education. When you get to the plan, there's one important question that you should ask twice. The first is when you turn to the resident and say to the resident, now what do you want to do? The whole point of being a physician is to be able to take information and synthesize it and put it together and then come out with a coherent set of things to do next. And you get to watch a resident do this if you ask them this question. And the next question is the same question, where the resident asks the patients, now what do you want to do? This is the beginnings of shared decision making. How can you see shared decision making if you're never present to witness it? Here's an opportunity to do that. Step 8 is involve the team. Now it's artificially here at step 8. You should be doing this the entire time. This is an organic process. If somebody has something to offer, to suggest, if there's a question of what else needs to be done, you can do that during the entire encounter. Step 9 for the attending physician, again occurring during the entire encounter, is to role model, teach all, and learn from all. Be the role model that you wish to be. Step 10 is Teachback. The path to adherence is self-efficacy. One of the greatest points of rounds is giving patients information that they can then use to care for themselves, and for the healthcare team to know what the patient knows about taking care of him or herself. So we ask this question: can you tell me what the plan is? Can you articulate what is happening today? This is a better question than do you understand the plan, because the patient can answer as a yes or a no. A better question: can you tell me what the plan is? And then you work with that patient to make sure that they really have it down. Step 11, another one of these steps is occurring all the time, is assessing the learners. This is your opportunity to see residents in action. Ideally, they're doing most of the work and you're assessing and then later giving feedback. As far as assessment, we should be doing assessment for learning, not assessment of learning. And this is a great example of assessment for learning. Miller described 4 levels of learner assessment. You can see what somebody knows, that's like test questions. You can see what they know how to do, that's table rounding. Them reading to you is at the know-how level. You can have them show you how to do something like putting in an ultrasound-guided IV. But what matters and what happens at the bedside is does. Now be careful. You'll see that I have put a question mark here by patient care. Because if we're not careful, patient-centered rounds can turn out to be the attending-centered rounds. And they are watching us and not vice versa. So you should be watching them do their work, giving them feedback based on what you observed. Step 12 is to organize work after rounds. We usually put the residents in charge of this step, asking what needs to get done. All those people that are sitting in the rounds today, the case manager, the pharmacist, the residents, what needs to get done? Work together as a team to plan that out. Step 13 is to debrief, reflect, and give feedback. Very important when you first start this rounds, on the first day after the first patient room, step out with your team and say, hey, how'd that go? And then refine, tweak it, fix it. It's like a series of plan, do, study, act cycles. You go back into the next patient's room, you come out and you debrief again. Usually takes about 2 to 3 days for a new team to fall together, to understand each other's roles, and to be fully functional. Step 14 is an important step for both residents and patients. Not everything that can happen will happen on morning rounds, and there needs to be some follow-up for sure. The resident should walk in again and ask, how'd that go for you? And maybe even do another teach back at that moment. Step 15 is to improve, repeat. There isn't one way to do this. Find the way that works best for you, your team, and your patients. I like this quote by Batalden and Davidoff. Everyone in healthcare really has 2 jobs when they come to work: to do their work and to improve it. We believe that wholeheartedly. You've just heard a brief tutorial on the 15 steps that we use at the University of Cincinnati Internal Medicine Residency for patient-centered rounding. If you'd like to see more information, again, we have many videos supporting this one. You can go to YouTube and type in the keyword UCINTMED and watch any of the videos for any of the parts of the encounter that you wish to watch. And we even have some longer form videos where you can watch the entire encounter from beginning to end.